Okay, good morning, everyone. Welcome to Wednesday morning cardiology grand rounds. A couple housekeeping things. Next week, we have an external speaker from Toronto, Dr. Wong. She'll be giving her a lecture virtually as she's situated in Toronto. So when you sign up for rounds next week, please note that it will all be on MS Teams, so there won't be an in-person component next week. Okay, let's get on with today's rounds. So it's my pleasure today to introduce Dr. Justin Morein. I asked Justin to speak today because we have had several cases over the past couple of years of anabolic steroid-induced cardiomyopathy and cardiogenic shock in the ICCU, and I've certainly seen numerous patients in the heart failure clinic regarding this, and so I thought it'd be timely to review this topic because we haven't done this in quite some time. So Justin kindly agreed to present today. He obtained his medical degree at the McGill University in Montreal, and then completed his residency in internal medicine at the University of Western Ontario, and then his endocrinology training here at the Ottawa Hospital. He's presently a clinical endocrinologist at the LMC Healthcare Centre in the community, and then the Ottawa Hospital is a lecturer with the University of Ottawa. So he kindly agreed to give this talk today, so thank you so much, and we look forward to your presentations.
Thank you. So, Justin, and it's my pleasure to be here today to talk to you about cardiovascular risk with testosterone use and anabolic steroid abuse. And I don't have any relevant conflicts of interest for this talk. And so our objectives today will be to determine the patterns of testosterone and anabolic steroid use and analyze the cardiovascular risk associated with those. And so I want to start off with a case I saw in one of my first longitudinal clinics as a fellow that sort of got me interested in this topic. So this young gentleman, 32-year-old male, presented for signs and symptoms and blood work showing hypogonadism. He didn't have any known past medical history and wasn't currently on any medications or anabolic steroids, but he was on a whole host of different supplements. Yeah, and just put the list there out of interest. But then on further history, he actually said since 2011 he was cycling on and off different anabolic steroids, and he starts naming them testosterone, oxandrolone, boldenone, and I start sweating because I haven't heard of any of these compounds that he's talking about. I'm worried that my supervisor is going to think I'm an idiot. And he said he got them mostly from the internet and used it just for bodybuilding. He wasn't an elite athlete or doing anything at a high level. And then he said he also used things like HCG, tamoxifen. And so these I had heard of, but I didn't know that they were used in this context. Also reported history of recreational drug use. But he actually stopped all of this in April 2020. And then after this, noticed these symptoms: reduced libido, erectile dysfunction, and other issues. And by this time, I was seeing him a few months later in the fall, I think, of 2020. So let's talk about the prevalence of this issue. And so first I want to talk about a couple of studies in athletes. And so that first one is a study in NCAA male athletes in the United States. And they found that the lifetime prevalence use was potentially as high as 20%. And it was actually associated with other substance use, including recreational drugs that actually could impede performance, right? Which is interesting. The second one was a really interesting study they did originally a long time ago called the Goldman Dilemma, because you can imagine it's hard to get truthful, correct information about an illicit use of a substance, especially in people that are at risk of their compromising their athletic careers. So back, I think in the 80s or 90s, they would pose this hypothetical question to athletes saying, if you can use a banned substance that would guarantee you success in your sport, gold medal, whatever that meant for you, but you would die 5 years later, would you do it? And in the original studies, up to like half of the athletes said they would take that deal. When they redid these studies more recently, the numbers weren't as wild as that, but they sort of posed different questions, and they said, okay, you wouldn't die after 5 years, but this is a banned substance, and you would know that you used it, but you would have complete success. And over 10% said, yes, I certainly would use a substance that would guarantee me success. And then they actually posed the question a little bit differently, and they said, okay, it's legal, you can use it, and you would have complete success in your sport, but you would die 5 years later. And still over 5% of the respondents of these, I think it was over 200 track athletes, said they would use it, they would do that deal. And then this last one was a review where they, more worldwide, and also quite high prevalence, estimated around 14, even up to 39% of elite athletes. And of course, that depended on the sport level and the subject's nationality. What about in the general population? So this Monitoring the Future survey was a really, really large US national survey from the 70s up until 2017, where they asked about all kinds of different substances, including anabolic steroids. And they found that 3 to 4 million people between the ages of 13 to 50 likely had tried anabolic steroids at least once in the US. And of those, around a third were chronic users, high dosage, not just one or odd usage. So quite high numbers. The second study there was a Swedish national survey. They found among men probably about 0.7% lifetime prevalence of anabolic steroid use and 0.02% in women. And this third one was a meta-analysis where they looked at 187 different studies worldwide. And they found a little bit of a higher prevalence, even 6.4% in men and 1.6% in women. But this was probably skewed a little bit. They included a lot of high-risk groups there. So overall, the worldwide lifetime prevalence is somewhere in the 1 to 5% range, which is not nothing. Many more males than females use, but females do use as well, of course, but there's very little data on that, unfortunately. And most chronic use is initiated quite early in the early 20s and even in the teens, actually. And so the users are typically athletes, bodybuilders, weightlifters, but even just people in the general population with body dysmorphia, and the so-called bigorexia. And so I just wanted to put this table from a really nice review by Bradley Anawalt, who does a lot of good work in this area, showing just the breadth of different compounds that people can use. Like on the left there, you see all kinds of different testosterone derivatives, which are basically designer anabolic steroid compounds designed to exert different anabolic and androgenic effects and also evade detection by the anti-doping agencies. People can use, of course, testosterone is a very commonly used one just obtained illicitly, and as well those other compounds like I mentioned, like SERMs and aromatase inhibitors to either offset negative side effects or boost further endogenous testosterone production. And so what are the patterns of use? Patients will often stack different steroids, use 2 to 3 different anabolic steroids at the same time in varying concentrations, and I'll show you an example in a moment. But they'll also add on non-steroidal drugs, which can also have negative effects cardiovascularly and otherwise, including human growth hormone, IGF-1, insulin. They'll include synthroid and diuretics to get rid of water and fat and weight. And they'll also do pyrimidine or cycling while they'll increase and decrease doses. And I'll show you an example of this on this slide here. So this is just like an example of what a cycle might look like for a patient, where they'll use testosterone, nandrolone, and metadione all together in increasing and decreasing concentrations, again, to get better effect, offset negative side effects. Towards the end of that, they'll add on something like HCG and anastrozole to offset some of the increased estrogen, which can cause gynecomastia, and as well testicular shrinkage. And then use SERMs towards the end to sort of jumpstart their own axis back. And of course, there's a lot of variability here, but just to get a sense of the type of complexity to the regimens that some of these patients use, and they'll do this for years on end. And you can see their doses of testosterone 1,000 a week sometimes, right? Which is 10 times what you typically would do. So when we want to assess the adverse effects of these types of regimens, it's really tough when talking about anabolic steroids because this is an illicitly obtained substance, right? And so we really are dealing with not the most robust data, not much prospective stuff, a lot of case reports. There's, of course, a lot of confounders in these studies because there's higher smoking and other substance use. And the other thing is these things are obtained illicitly from the internet elsewhere. So when we're looking at the adverse effects, are we measuring the adverse effects of these compounds or of this counterfeit contaminated stuff that this person might be getting, right? And so before we jump into CV effects, I just want to mention some of the other systems that are affected. Hepatic system for sure, especially these oral alkylated anabolic steroids that some will use. Erythrocytosis, gynecomastia is common. Maybe some renal damage, although unclear if it's just contaminants or adulterants. MSK for sure, tendon rupture, especially in the upper extremity, is very common on high doses, as well as acne and alopecia. And so what about cardiovascular effects? And so I think as early as the 1980s and 90s, there was case reports coming out of sudden cardiac death and acute MI in very young patients with anabolic steroid use. And as well, some of the early data on dyslipidemia is the strongest we have, showing consistently lower HDL, as well as other changes. But there's also data for hypertension, myocardial infarction, LVH, cardiac remodeling, scarring, cardiomyopathy, arrhythmias, and hypercoagulability. And I'm going to go through some of that data now. So first off, I just want to show one of the older studies that they did for cholesterol, where they took 14 adult men and they assessed their HDL, LDL, and triglycerides. And they did that during active physical conditioning while they were on anabolic steroid for at least 1 month, and then actually compared them to when they were off. It's not cut off, is it? It's cut off a little bit, actually, the bottom. Anyways. And they were off the steroids for 4 months, so they sort of used them as their own control. That's better. And so they actually found that on the month that these subjects were on the anabolic steroid, they actually had a mean HDL of 0.75, and in the months when they were off anabolic steroid, their mean HDL was 1.58, so it was lower by over 50% from when they were off it. And as well, the LDL increased a little bit, but to a less substantial degree. And there's several studies showing similar results. And what about cardiac hypertrophy? And so there's actually been a good number of studies on this. There's been some animal models, for example, this one, where they looked at female mice and then had them sedentary exercise and then plus or minus anabolic steroids. And they actually looked at the LV papillary muscle at 3 and 6 weeks. And in the mice that were exercise and anabolic steroid use, they actually saw that it induced cardiac myocyte hypertrophy and impaired cardiac microvascular adaptation to that physical conditioning. And so what about in humans? So there have been several post-mortem studies showing cardiac structural changes in anabolic steroid users. A good literature review in 2020 showed that in anabolic steroid users who had sudden cardiac death, up to a third of them had cardiomegaly, including 30% with LVH and 9% with dilated cardiomyopathy. This study here was an interesting one. It was a postmortem pathology study, and they looked at 87 deceased men that tested positive in the urine for AAS use and compared it with controls. And what they found was similarly, over a third of them, the AAS users had cardiac hypertrophy who died of unnatural causes, so poisoning, suicide, et cetera, not from necessarily a cardiovascular cause. And they had significantly greater cardiac mass, with 12% of them having cardiac mass over 500 grams compared to just 7% in the control group. And you could see there whether they had a bleeding traumatic death or not. That, I guess, changed the weight of the heart. It was an increase in AAS users compared to controls. And it didn't really change when they adjusted for other illegal substances that they were aware of, or when it was not related to their increased body mass either. And so what about function? So there have been several imaging studies as well, again, small numbers, but that did demonstrate overt cardiomyopathy in anabolic steroid users, and including reduced ejection fraction. And so this one here was an echocardiographic assessment of LV function, LVF, and diastolic indices. And so they compared these parameters in 12 weightlifters with long-term AAS use compared to 7 weightlifters without. And so I tried to make it as big as I could. Hopefully you can see the table there. But basically, interestingly, the LV structural parameters, I think you can see at the top there, are actually pretty similar between the groups. But in the AAS users, they had significantly lower left ventricular ejection fraction, about 50.6% versus 59.1%. So roughly 9-10% lower, and a lower longitudinal strain percentage and radial strain. And the AAS users also demonstrated decreased diastolic function. They had a markedly lower peak E wave velocity and the lower E to A ratio. And so here you can see that of the 12 AAS users, 10 had an LVEF lower than 55% into that HFnF range, whereas only about 1 out of the non-users had an EF under 55%. And then here they included this in the study. This, I guess, picture of the waveforms doesn't mean so much to me, but maybe to some of you folks, just to see out of interest to look at it. But I can see that there's a clearly difference between these two samples that they put, where there's a diminished E, E compared to A, which is apparently a hallmark of impaired LV relaxation and diastolic dysfunction. just as an example there. And there's a couple other studies that show these similar type of results. And so just quickly here, the same group actually published a more recent study in 2017 and had even more subjects. They had 86 AAS users. And there's a couple of interesting points here. They actually replicated that similar systolic and diastolic dysfunction. Again, a roughly 10% reduction in EF and diastolic parameters. But a couple of things they noted that were interesting was in the green box, you could see that actually they did see a difference in the structural parameters, heavier heart, thicker walls in the ventricle. And they actually also did a comparison of on use and off use. And they actually found that there was the LV EF did improve a little bit when they were off, whereas the diastolic dysfunction persisted. And that tells us maybe there's actually some components that are reversible when you stop AAS use and some that might not be. It might be permanent. And so what about arrhythmia? And so there's been a couple of studies like this where they basically look at the EKG parameters before and after submaximal exercise. They did that in 11 AAS users here and 11 non-users, again, small numbers. And then they measured these at rest and at post-exercise recovery time. And so what they found was that in the AAS users, they had a shorter RR interval, a prolonged QTC at rest, and a prolonged increase in QTC post-exercise. And in the control group, it had not changed much. And as well, the AAS users had a much greater QT dispersion with a rest value over 65 milliseconds. And again, I'm not an expert in this field, but my understanding is that might indicate that there's potentially scarring or different rates of repolarization in the ventricle. And so they also found that the AAS users had a prolonged post-exercise QTC max and QTC min and a lower heart rate recovery time. All in all, I believe suggesting that there's certainly ventricular repolarization abnormalities that might predispose to fatal arrhythmias. Right. And then, so what about like hard cardiovascular outcomes? So this is actually a really nice study just published a couple of months ago that I came across when I was starting to prepare for the talk. And so this was a collaboration between fitness centers in Denmark with the anti-doping program. And basically what they want to do is identify and then sanction AAS users. And so what they did was they identified anybody that was sanctioned who tested positive or refused to be tested, and then followed them for a mean of 11 years to see what sort of cardiovascular outcomes there were. And they compared those to 50 age and sex matched controls, and they assessed for a variety of different outcomes. And so what they found, there was a significantly increased risk of all of these outcomes. And I'll show you the numbers in a second, but increased risk of MI, revascularization, venous thromboembolism, arrhythmias, cardiomyopathy, and heart failure. And this was time to CV events and the risk of CV outcomes over time. And so I added in blue and red and blue there, the percentages there, the crude numbers. And you could see, significantly higher rates of most of these events in the AAS users in red there on the left, and then compared to controls on the right, giving adjusted hazard ratios of around a 2-3-fold increased risk and up to close to 9 for cardiomyopathy. So this was a really nice study because they had 1,100 AAS users, so much bigger numbers than most of the other studies we've had before, right? Compared against to 60,000 controls. So this was very interesting. Yeah, and arrhythmia was the most prevalent, with the SVTs being most common. And the other interesting point, they noted that in the cardiomyopathy, it was actually a little bit different, the pattern. The number was obviously much higher, but also in the controls, it was actually more dilated cardiomyopathy, whereas in the AAS users, they found more of this non-obstructive hypertrophic type of cardiomyopathy. So how do we detect AAS use or know if someone's using? So there are no practical diagnostic tests we can use. The fancy tests that, the World Anti-Doping Agency uses at the Olympics and things like that, we don't have them available. And even if we did, it would be very easy to avoid detection in the outpatient clinical non-supervised setting. So when would you consider it? So of course, from cardiology perspective, when you have a young person without another etiology presenting with these significant adverse cardiovascular outcomes, especially if they're more muscular, if they have any history of gynecomastia and fertility, if you can see some of their labs, the HDL might be quite low if they're actively using. SHBG, again, if it's been checked, would be low, and they might have a high hemoglobin and hematocrit as well, right? And the other thing is most of these compounds will suppress our endogenous testosterone axis, right? So if you have it, cardiologists likely won't be measuring, but we do, and it might be seen. But the FSH and LH, if you can see it, would be quite low if they're actively using when that blood test was drawn. But the most useful thing is just asking and then counseling on them. All right, and so in terms of our knowledge in this area, so there's still a lot of gaps, right? Because we don't have a lot of prospective systemically gathered data, and we don't have really reliable current epidemiological data, right? A lot of that stuff I presented was sort of surveys and questions. And the other big thing is we don't have RCTs addressing the therapies for treatment for withdrawal of AAS, because you do get hypogonadal withdrawal symptoms if you stop, and that prevents a lot of patients from being willing to come off, right? And so that's a big issue. So now I'm going to switch gears to talk about prescription testosterone use in hypogonadal men. And so, of course, before we decide to treat someone with testosterone, we want to make sure we have a firm diagnosis of hypogonadism, which involves someone having signs and symptoms of testosterone deficiency, and as well as unequivocally and consistently low serum total testosterone or free testosterone checked on multiple occasions, because there's a lot of variability day to day. And when I'm trying to diagnose someone, I try to look for some of the more specific and suggestive signs and symptoms. So reduced libido, sexual activity, erectile dysfunction, decreased erections, change in hair pattern, potentially gynecomastia, infertility, and less so just on those less specific type symptoms on the side, but those, of course, are associated with it as well. And so before we get into the adverse effects, we want to know, okay, is there actually benefit there, especially for, middle-aged and older men with idiopathic central low testosterone without, an organic pathological cause? Because if there's no benefit, then we shouldn't be treating anybody for any reason, right? So the trials, the testosterone trials, was a good set of 7 placebo-controlled trials where they looked at almost 800 older men with low testosterone, and they treated them with testosterone gel for about a year and looked at benefits and adverse outcomes. And so they did find they did have increased sexual activity, increased physical function, improved anemia, both explained and unexplained causes, and increased bone density and strength. So what about risk and cardiovascular specifically? So up until 10, 15 years ago, testosterone therapy was actually considered quite safe, and there was not a lot of data for harm. There's, the meta-analyses consistently showed erythrocytosis with increased risk of elevated hematocrit. But when they looked at cardiovascular outcomes, it was often, sometimes a trend towards increased cardiovascular events, but nothing that was statistically significant. And so it was only really as of 2010 and beyond that a few studies came out that really changed the thinking in this area. And so this is one of the main ones. The testosterone in older men with mobility limitations trial was an RCT in 2010. They wanted to look at about 250 community dwelling men with mobility limitations who were over 65 and hypogonadal, and treat them to see what the effects of testosterone gel would be if it would improve strength and physical functioning. Interestingly, they actually halted the study early because of safety monitoring, because there was increased adverse effects in general, but mostly cardiovascular concern. Is there's 23 events in the testosterone group and only 5 in the control group when they stopped the study. And in their time to event analysis for these, they actually gave an odds ratio of a cardiovascular event of 5.4. And so that was raised a lot of concern for a lot of people. Just to note, it was a pretty high risk population. Over half had pre-existing cardiovascular disease or were at high Framingham risk score. And it did seem that it was dose dependent and testosterone level dependent in terms of the risk of these cardiovascular events. However, there's a few very important things to note about this trial. Obviously, cardiovascular events was not a primary or even secondary outcome, right? It was just an adverse event reported. Very small number of patients, small number of events in an older, more frail population. They also weren't perfectly balanced. The testosterone group did have higher dyslipidemia and statin use. But the most important thing, and sorry if it's a bit small, I made the table as big as I could, but many of these events, of these 23 and actually 25 events in the end reported, they said cardiovascular events, but 5 of these were peripheral edema, 2 were syncope, 1 was PVC, 2 were elevated blood pressure, right? These weren't major adverse cardiovascular events. So it seemed a lot worse and different than probably the reality. And when they looked at just these sort of atherosclerosis events, there was actually only really 7 in the testosterone group compared to 1 in the placebo group. So a very different story. And even the authors themselves admitted that, a big conclusion shouldn't necessarily be drawn from this data. But there was some other papers as well that increased this concern. This study was a retrospective cohort study, came out a few years later, and they basically took male veterans in the VA who underwent coronary angiography, and then saw of those ones who had a testosterone reading which was low, and that was 8,700 of those. And they compared the ones that did start testosterone with that compared to not. And there was about 1,200 of the 8,700 that were prescribed testosterone therapy. And then they looked at a 3-point MACE of mortality, MI, or ischemic stroke. One of the interesting things with this was they did this so that they could see what the baseline coronary artery data would be, right? And see if they can compare outcomes. And so, this as well was obviously a high-risk population because there are people that underwent angiography. So a lot of them had obstructive coronary disease, diabetes, obesity, CHF, and prior MI. And so what they did find, they followed them for about 27.5 months. And so in the accrued numbers, they actually, in the unadjusted absolute risk, there was not a difference between the two groups, but the placebo group was a little less healthy and had more comorbidities than the testosterone group. So when they adjusted for these variables, then all of a sudden it gave a positive hazard ratio of 1.29 for cardiovascular events in the testosterone group. And then this, again, they reported saying, well, so then testosterone causes an increased risk of these 3 cardiovascular events. But if you looked at the crude numbers, it was actually lower in the testosterone group and only changed when they adjusted for these many variables. Interestingly, it was actually unchanged whether they had baseline CAD or not for these outcomes. But as well, like the other one, there was a few important limitations in the study. I won't go through all of it, but basically not a great sense of how many people actually completed testosterone, how long they took it for, and what levels they got to. And then the third study that really created concern was this observational study published in 2014. And this was a large cohort study of over 55,000 patients. And they basically looked at just the risk of acute non-fatal MI following an initial testosterone prescription. And they wanted to compare the incidence rate of MI in patients who received testosterone and just in the 90 days after they got their first prescription. So basically looking at just acute effects of testosterone replacement therapy. And they compared that to the risk to the rate of MI in the same patients for the year prior to the testosterone prescription. So they sort of use them as their own control. And they also compared those post and pre rates to cohort of men that used PDE5 inhibitors. And so what they found was when they compared the rate of MIs pre and post testosterone prescription, there was an increased rate ratio of 1.36% for non-fatal MI in the 90 days following a first testosterone prescription. And this was mostly significant for patients over the age of 65. When they broke it down by age and prior heart disease history, in patients under 65, it was actually mostly only those with a prior cardiovascular disease history that had an increased rate of MIs after testosterone. Whereas in the patients that were over 65, whether they had a history of or not, they had the increased about a 2-fold higher rate of MIs in that first 90 days following the first testosterone prescription. Of course, some limitations there, a little bit of an odd study design where you're comparing to pre and post prescription in the same patient. To me, of course, if they had an MI or not prior, that would potentially impact whether you prescribe testosterone. Although again, at this point, it wasn't yet a huge concern, but still interesting. And as well, this is of course, just looking in the acute setting, but we don't know, they actually didn't ascertain why they were prescribed testosterone, were they actually hypogonadal to begin with, etc. And so finally, this was around the same time a systematic review and meta-analysis. And this was a study looking at RCTs, giving cardiovascular events by study arm. And they looked at close to 3,000 mainly older men. And their primary outcome was a composite of cardiovascular events. And as opposed to this previous study I just mentioned, they looked at only therapy for 12 weeks and beyond, so chronic use, not the acute use of testosterone. But there was lack of detailed cardiovascular event reporting, so they couldn't get of cardiovascular event subtypes in their analysis. And they used a very broad definition of cardiovascular outcomes. Basically, anything that the authors said were cardiovascular outcomes, they included in the study. And with that, they did show that there was an increased odds ratio of all cardiovascular events, 1.54, taking it all together. And it did hold when they did try to restrict it to serious cardiovascular events. So we avoid some of those issues like we had in that first Basaria trial in 2010. And this didn't seem to differ based on their baseline testosterone level. But again, there was significant limitations with this study. So about a third of the patients for this analysis included that 2010 study where there was those 25 events that, again, we don't think a lot of those were technically major cardiovascular events. And as well, another really old study from the 80s, a Copenhagen study, where they gave like gigantic doses of oral micronized testosterone to patients with like cirrhosis. So a very odd, intense study, and that was also a big number of events. So if you take out those two studies, the odds ratio is actually close to 1. So those were basically the main studies that led the FDA and Health Canada, as well as with public pressure, to actually put a label on testosterone to say possible increased risk of cardiovascular disease. And as well, Endo Society and other societies to also put that sort of wishy-washy, there may be increased risk. But a lot of recent observational studies and systematic reviews actually have shown a more neutral cardiovascular risk with properly prescribed testosterone in properly diagnosed hypogonadal patients. And actually, besides the zoo study, 19 of the 20 meta-analyses did not find that increased cardiovascular risk. And since then, over the last few years, there's been several RCTs of testosterone therapy, looking for other outcomes. Cardiovascular outcomes wasn't the main outcome, but they didn't really find any increased cardiovascular adverse events. And these few studies that have shown the positive signal do seem to suggest the increased risk is probably early after testosterone initiation. And so before I get into some of the data, I just wanted to make the interesting point that, we do know pretty consistently in the studies that low endogenous testosterone levels actually is a sign of worse cardiovascular health. And so some studies even show cardioprotective effect when your endogenous testosterone levels are higher. And lower testosterone levels have been associated with increased mortality, atrial fibrillation, and some other studies haven't shown as much of an association. Of course, that doesn't imply causality, it's just a correlation, and it's probably honestly reverse causality where the poor health has led to lower endogenous testosterone levels, right? But it's interesting nonetheless. So I want to just talk about atherosclerosis quickly. There's a couple of mixed results on that. And so the couple of good trials on this one was the TEAM trial, and it was a RCT in 2015 where they looked at over 300 men over the age of 60, and they wanted to see the progression of subclinical atherosclerosis for patients with hypogonadism who were targeted to the mid-normal range for 3 years of treatment. And they excluded people who had an MI in the last 6 months or advanced heart failure. And so their main primary outcomes, co-primary outcomes, was a change in the carotid artery intermediate thickness and coronary artery calcium score. You can see on the left there, they had an increased testosterone level compared to placebo. Of course, it did approach closer to placebo towards the end, but they did not find a significant increase in artery intermediate thickness or the coronary artery calcium score in those that were treated with testosterone compared to placebo. And then, while it wasn't the main outcome, they did look at the cardiovascular events, and they said they were similar between the two. But actually, there was actually 12 in the testosterone group and only 4 in the placebo group. But when broken down by the subtypes, there was one or two more, revascularization, MI, et cetera, which they didn't comment on the significance of, really. And so one other main study looking at the atherosclerosis was those T trials that I mentioned before. One of those 7 trials was the cardiovascular trial, where they had 138 men in that trial that had CTA at baseline and then after 12 months of testosterone gel therapy. And what they did was they compared the progression of non-calcified coronary artery plaque volume. And they also looked at total plaque volume, the components of the plaque, and coronary artery calcium score. So here they did actually see that the testosterone was associated with a greater increase in non-calcified coronary artery plaque volume. And you can see the changes in the volume there on the left. And interestingly, actually, there was no cardiovascular events in either group throughout the 1 year of the trial. And so some of the differences between this and the other trial was in this was a higher risk population. And as well as you can see on the left there, the baseline coronary plaque volume was already a lot larger, 50% larger in the placebo group compared to the testosterone group. So I don't know if that would necessarily impact the rate of progression. If it's sort of already a higher volume, maybe it doesn't progress as fast. So a couple of important issues there, but interesting nonetheless. So a little bit of mixed results. And the other thing for that study was when they looked at the plaque volume, the total plaque volume was also increased. But in terms of the non-calcified plaque volume, apparently the fibrous component had increased a little bit more. So they were reporting apparently potentially still like a stable-ish plaque, not unstable, but yeah. And so what about some of those harder outcomes? So like I said, there's been a few meta-analyses. I really like this one because it's pretty recent, and they actually had one of the studies with the most cardiovascular events in total, over 300, and they actually tried to get as much individual patient data as they could, not just aggregate data from the studies. And so they were able to gather 35 studies, over 5,600 patients. And they of those 17 of the studies, they were able to get individual patient data for in events. And the mean duration of follow-up was about 9.5 months, so a little bit short. And then the other 18 studies, they had just aggregate data for. And so what they found was when they compared the patients who received testosterone to placebo, there was very similar rates of adverse cardiovascular events, and as well similar rates of cardiovascular event subtypes in the individual patient data with an odds ratio of 1.07. That was not significantly different. And so when they did the individual patient analysis, yeah, like we mentioned, odds ratio of 1.03. And then when they did the aggregate data separately, there actually was a odds ratio of 0.35. It actually almost favored the testosterone group in terms of cardiovascular outcomes. And putting all of it together, again, not a big statistical difference between the two, showing that in this really large meta-analysis of thousands of patients, that there was not a clear increase in cardiovascular events. And so this was a strong study because they had to get more CV events than pretty much any of the meta-analyses before. And the CV event subtypes were similar between the groups. Although the arrhythmia, coronary heart disease that was not otherwise specified, and I think heart failure were the ones that were most common in both groups. And age or previous CVD were not associated with increased risk. And they didn't identify any patient characteristics that seemed to significantly increase the risk. But of course, there was pretty short follow-up, less than a year on average, and was missing a lot of the IPD data for different reasons, which could have affected the results. So finally, I just wanted to talk about the Traverse trial, which came out a couple of years ago. And so this was basically mandated by the FDA because they said, because of this increased concern for cardiovascular disease, we want a cardiovascular outcome trial to sort of try to answer this question more definitively. So the testosterone manufacturers had to sort of perform this trial, and it was published a couple of years ago. So it was basically a multi-center non-inferiority trial of over 5,000 men, age 45 and older, who are high risk pre-existing cardiovascular disease, or at least high risk for cardiovascular disease, who had confirmed hypogonadism, and they were treated with testosterone gel, mean duration of just under 2 years. But they did exclude severe hypogonadism, thrombophilia, and recent events in the last 4 months. And so as you can see that they were a pretty high risk population. The over half had pre-existing cardiovascular disease, and the rest were considered to be at high risk and had other comorbidities as well. A high percentage of type 2 diabetes, hypertension, and obesity. So it was a good population. And so their primary cardiovascular outcome was 3-point MACE of a death from cardiovascular cause, non-fatal MI, non-fatal stroke. And in the safety population analysis on the left, which was basically anybody who had received 1 dose of testosterone or placebo, they found a hazard ratio of 0.96 and testosterone being non-inferior to placebo for cardiovascular outcomes. And this held in their sensitivity analysis, where they also included for the year after testosterone use, just to see for any delayed events or effects, and still no changes in cardiovascular events in that testosterone group compared to placebo in this high-risk population. And so their secondary composite outcome was basically those 3 outcomes, plus they also included revascularization, and that was also very similar between the 2 groups. And there was also very similar outcomes for all the components of the primary and secondary outcome. They also looked at heart failure, hospitalization, and that also was similar between testosterone and placebo. But a couple of interesting things from this study, which they didn't discuss so much, was that VTE overall was similar, but it was actually double the amount of PEs in the testosterone group. There's actually also more fractures and a higher risk of AFib in the testosterone group. Again, it wasn't an outcome that they were seeking. I didn't comment too much more on that, but just some interesting findings there. And I think that's about it. And I'm happy to have a discussion, answer any questions, see what people think of the data.
Thank you so much. If there's any questions, I can bring you the microphone or you can put them in the chat box. I do have a question about the patients that are on anabolic steroids. So we see them on occasion, and obviously we counsel them to stop. But if they've been on anabolic steroids for a long time, should we be referring these folks to endocrinology? Because I presume their whole HP axis is going to be very suppressed if they were to stop.
Yes, that's a really good question.
What's the management strategy there?
Yeah,
assuming they agree to stop.
Yeah, exactly. So I actually had some slides on that, but I hid them because I was worried I was going to run out of time. But basically, yeah. So it's really tough because their eight axis is suppressed. So if they stop cold turkey, they'll basically have hypogonadism. And depending on the doses and how long they used, it could be months, even years sometimes until the axis recovers. But it will almost invariably. So it's very rare to get actually permanent dysfunction from anabolic steroid use, even high dose for a lot of years, unless they have some other pathology. But that's the big barrier because we don't have good, we don't have like RCTs or data to say, oh, this is the right way to come off of anabolic steroids. Technically, it's safe and fastest to literally actually just stop it all cold turkey and just ride it out until their axis recovers. I've had a few patients, young patients, they're on high doses for a long time. Within a few months, they actually were back to normal. Obviously, they didn't feel so great at the beginning, but the main thing is counseling them on that and knowing what to expect. Yeah, you're going to have some of these symptoms and signs. Some providers who have experience in this area, especially in the States, they will do things as like a harm reduction and stuff to help that process, but it's totally off label. So some people will say, okay, if you're willing to do this, you sign something, I'll prescribe you testosterone replacement at just 1 or 2 times physiologic and then slowly taper that. Again, not data, a lot of data for that. That's one thing you can do. Or again, you can stop things and then add on things like HCG or SERMs like clomiphene, and that helps jumpstart the access a little faster, or increase, HCG specifically is more helpful if someone's main concern is fertility. That's actually an often reason why these patients eventually come off, right? Because they're starting in their 20s, and then once they're late 20s, early 30s, they have a partner, now they want to conceive, but they have no sperm or very poor motility in numbers, and they want to come off. So sometimes they'll use HCG or clomiphene, again, totally off label, but to help jumpstart that access. So you could use that, and that could help with symptoms and stuff like that. But really the best way is to actually just stop cold turkey. But that's why that's a big barrier why patients don't want to come off.
And one other question. So you sort of the first half of your presentation that you were showing prevalence or incidence of the development of heart failure, but it looked like your curves diverged late, not in the first 2 years.
Yeah.
Any thoughts about, delayed presentation with use?
It's tough. Nothing that I've come across that's like addressed that so specifically. I wonder if, again, a lot of it's observational stuff and recall of, oh, when I use this substance for how long and what dose. So I wonder if it's, potentially as people, when they're younger, and then as they get more into it, they're probably increasing the complexity, dosage, and length of their cycles that they're using. So it might be only later on as with higher usage as time goes on. Also, again, these are otherwise ostensibly young, healthy people. So, it probably takes time to develop these cardiac changes. Like I show in one of the good studies, they actually didn't even see structural changes of the heart, just a starting reduction in EF and other things like that. So it probably takes time, and they probably up the intensity of their programs as the years go on. And so that might explain the delay.
Okay. Well, thank you so much for your presentation today. I really appreciate you taking time to come speak with us. Everyone sign up for rounds next week, please. It will be virtual only next week, so don't attend in person. And have a good week, everyone.